All right, thanks everybody for being here for our AMSSM ultrasound case series today. Just want to start off like we've been doing the past few weeks, is plugging our sports ultrasound pathology for the library. So I just wanted to put this out there again that we're collecting sports ultrasound images. These are open to any attending or trainee. Again, this is something that would be good. You can put on your as a publication on your CV. These will be published on the AMSSM website. Currently, I think we're looking for pictures for elbow pathology. So you can submit those. Again, if you have questions, you can send an email to the emails listed on this slide. Use the QR code to get to the library link to submit your cases for that. All right. Without further ado, I'll introduce our speaker today. It's my pleasure. I get to introduce my co-fellow here. This is Dr. George Raum. He's going to be presenting on posterior shoulder pain. George is currently a primary care sports medicine fellow at Emory University. He started his path as a student athlete at Franklin and Marshall College in Lancaster, PA. He obtained his degree in osteopathic medicine from Philadelphia College of Osteopathic Medicine before completing his residency training at UPMC in physical medicine and rehabilitation. He currently serves as a fellow associate chair for the one-on-one customized workshops for this year's AMSSM meeting. He'll be practicing sports medicine as an attending next year in Charlotte, North Carolina. All right, George, so I'm going to hand this over to you. Again, this is George Raum presenting on posterior shoulder pain.
Awesome. Thank you so much for having me. I've been watching these sessions for a long time, dating back to medical school. So it's an honor to be presenting here today. So our objectives today, we're going to describe the ultrasound protocol for the complete shoulder exam. We're going to describe the sonographic findings of internal impingement and the relevant dynamic maneuvers. We'll review the ultrasound report for this case, and then we will have some group discussion with some of our experts on the call here. I have no disclosures relevant to today's presentation. And I would like to take the time to acknowledge my ultrasound mentors, everybody here at Emory Sports Medicine, including my co-fellow who's hosting here tonight, this morning. And of course, Dr. Ryan Nussbaum, who kind of got me started with my trajectory musculoskeletal ultrasound up at UPMC. So our case today is a 29-year-old right-hand dominant former softball outfielder. She was told in the past that her scapula moves funny, diagnosis of scapular dyskinesis. She was being treated and managed by a chiropractor. She was previously an elite level softball player at the collegiate level. Currently, she just plays slow pitch softball, does general fitness with cardiovascular exercise and strength training. She's had shoulder pain on and off for a long time, pretty much as long as she could remember during her softball career. But this time around, she's presenting with 3 months of atraumatic posterior right shoulder pain with occasional clicking, most notable in the late cocking phase of the throw. She's also complaining of decreased throwing power and pain with overhead pressing and overhead lifts. She's never had a medical workup. She's just been evaluated by a chiropractor. She's done some exercises here and there for this and has gotten some manual therapy done for this. For our patient's physical exam, she had increased scapulothoracic elevation of the shoulder with shoulder flexion and abduction. She was tentative palpation over the posterior shoulder joint and the greater tuberosity. And then notably, when we looked at her range of motion, she had the classic findings of glenohumeral internal rotation deficiency with excess external rotation and limited internal rotation of her throwing right shoulder with a maintained arc of 90 degrees. She also had a positive O'Brien's test and pain with existed external rotation, both at the 90-90 position and at the neutral position. Differential diagnosis for shoulder pain in the throw is very broad, and ultrasound can help us narrow this down. So it includes the findings associated with subacromial pain syndrome, labral pathology, cervical radiculopathy, peripheral nerve entrapment, including neurogenic thoracic outlet syndrome, and myofascial pain as well. For any ultrasound scan, it's really important to understand the underlying anatomy of what we're going to be looking at, but this is extremely important for the shoulder due to the different directionality that some of the tendons and structures that we're looking at are coming in at. Especially the rotator cuff tendons and the way they insert on the humeral head. So here's a few different renditions of the way that the rotator cuff comes around from the posterior and anterior and it inserts on the lesser and greater tuberosity. These are from the MSK Room textbooks, which is one of my favorite ultrasound textbooks, and the Bianchi textbook. This is a sagittal slice of the humeral head, and what we can see here is the layout of those rotator cuff tendons as they come and insert on the superior, middle, and inferior facet of the greater tuberosity. With some overlap between the infraspinatus and supraspinatus as they insert on the greater tuberosity. and then the subscapularis wrapping around anteriorly and inserting on the lesser tuberosity, with the biceps tendon coming up and running up through that bicipital groove and heading towards the superior rim of the glenoid. So it's just important to understand the directionality of these tendons and understand why we're putting patients in certain positions throughout the scan in order to appropriately image those tendons. It's also helpful to understand the cross-sectional anatomy especially as we're looking at the posterior shoulder. This is a axial MRI slice looking at the level of the glenohumeral joint, and we can see as the infraspinatus wraps around the back of the joint, we have the underlying glenoid labrum, posterior joint capsule, and that posterior glenohumeral joint. So now we'll move on to the complete ultrasound examination of the shoulder, and I'll try and point out as many tips that help me, especially as a beginner, with scanning the shoulder, and then we'll move into talking about the pathology that we saw. So patient positioning, as I alluded to for the scan, is extremely important in order to expose the appropriate structures and put those structures under tension as we're evaluating them. So you could do this scan either in the seated or the lying position. Some people will do it lying in supine. Some people will do it lateral recumbent. As long as you can move the patient's arm in space, you'll be able to complete this scan. I completed the scan seated. I usually do this scan seated, but there are times where I will do it in the supine or lateral recumbent position. But we will be moving the arm from a neutral supinated position to an external rotated position, as well as the modified CRAS position and the adducted and internal rotated position. And I'll indicate these on the slides to indicate which position I was using to scan the patient and appropriately image the structures of interest. For our transducer selection, for most of the scan, I used a mid-frequency linear probe, and for a majority of these structures, that would be the appropriate probe to use. There are times where a curvilinear probe is helpful for deeper structures in the posterior shoulder, the joint, the suprascapular notch, or if the patient does have a larger body habitus, it is helpful to use that probe to penetrate deeper. Moving into our shoulder complete scanning protocol, this was the protocol published by the AMSSM. We're going to be looking at the biceps tendon, the tendons of the rotator cuff. We'll be doing some dynamic assessment of the biceps tendon, subcoracoid impingement, as well as external impingement dynamic testing. We'll also be looking at the AC joint, the posterior glenohumeral joint, the spinal glenoid notch in that complete protocol with the coracoacromial ligament as well. And then some of the optional structures based on the clinical question and the history and physical that would be included vary, but for this case, we'll be looking at the rotator interval, and we'll also be looking at the suprascapular notch. So we'll get started with our shoulder scan. The first structure for most people that scanners would use as their home base, and that I use as my home base, is the long head of the biceps tendon and short axis. So we're going to have the patient in a neutral supinated position. We're going to place that probe in the axial plane across their anterior shoulder, and we're going to identify the greater tuberosity and lesser tuberosity with the hyperechoic biceps tendon sitting centrally. You may have to apply some WAG and heel toe pressure in order to brighten up this tendon and level out the tuberosities appropriately. And we're going to scan both superiorly and inferiorly along this tendon as it reaches its myotendinous junction, and later superiorly as it heads through the joint in order to look for pathology. For the biceps tendon, we're looking for surrounding fluid around the biceps tendon, which could be indicative of tenosynovitis or even a joint effusion, as the biceps tendon sheath does communicate with the glenohumeral joint. We're looking for any thickening of the biceps tendon, any defect of the biceps tendon, any hypoechogenicity within the tendon. And we could also look for sonopalpation and throw on Doppler and look for hypervascularity as well. Here you can see as we scan inferiorly, the biceps tendon reaches its myotendinous junction and runs underneath the pectoralis major tendon here. And that's how we know we've scanned distally enough to image that tendon completely. We'll then flip the probe into long axis in that sagittal plane, looking at the long head of the biceps tendon as it runs through the bicipital groove. We want to, again, may have to add heel toe pressure in order to appropriately align the beams with the biceps tendon and brighten up that tendon and get rid of the anisotropy. Again, we're looking for all the things we talked about for discontinuity, thickness of the tendon. We can look for hypervascularity, fluid surrounding the tendon. We're going to scan from medial to laterally, and this is helpful to scan through the full width of the tendon. And you could use the shape of the tuberosities in order to indicate where you are. So the greater tuberosity has this more rounded shape, and the lesser tuberosity has this peaked appearance, just to help align yourself as you're beginning to scan this tendon. We also scan distally to the myotendinous junction and fully evaluate the tendon. Here, the long head of the biceps tendon does appear normal. Moving on, as we scan superiorly, we're going to find ourselves up near the rotator interval, and we could look at some very important structures here. So we're going to scan superiorly on the biceps tendon towards its insertion at the superior glenoid rim. We could do this scan either in the modified CRAS position or in the neutral position. As we course towards the intra-articular portion of the biceps tendon, we are going to have to follow its course towards the glenoid rim. Therefore, we're going to need to angle the probe with the medial end of the probe slanted inferiorly and the lateral end of the probe superiorly. The biceps tendon is going to take on this ovoid shape as we get to the rotator interval, and we will see the surrounding structures of the supraspinatus and the subscapularis. And this is very helpful because we're getting the terminal fibers of these structures at their insertion, and where pathology can take place. So it's a really helpful area to evaluate these at. We're also going to have the coracohumeral ligament and the superior glenohumeral ligament. We could look for thickening of the coracohumeral ligament in the case if we're concerned for frozen shoulder. And this is also a very helpful view for procedures because you have access to the subacromial subdeltoid bursa and the joint itself as you introduce the needle deep to the coracohumeral ligament. So this is a very helpful view, both diagnostically and procedurally. For this patient, there's no pathology indicated at the rotator interval. Then we'll move on to the subscapularis. We're going to change our patient positioning again. So we're going to get the subscapularis tendon under tension and expose it from underneath the coracoid. So we will have our patient go into external rotation. Here, we're going to align the probe. I like to initially image the subscapularis in short axis to get an idea of the full footprint of the subscapularis because it's such a broad tendon, and then scan it out as it inserts on the lesser tuberosity of the humerus. Here, you're going to have this classic appearance of interwoven muscle and tendon fibers, as you can see here and here. This is important not to confuse this with pathology. It's a very normal appearance of the subscapularis tendon. Most of the pathology in the subscapularis does happen in the upper 50% of the tendon. So imaging it in short axis just helps understand the full lay of the land when it comes to imaging the subscapularis. Anytime we're looking at one of the rotator cuff tendons, as many tendons in the body, we're looking for a few different things. We're looking for cortical irregularity deep to the tendon as it inserts on its destination bone. We're looking for thickening of the tendon or changes in caliber of the tendon where it thins out as well. We're looking for areas of hypoechogenicity, and then we could also look for increased vascularity by turning on Doppler and looking there as well. Then we'll flip the probe into long axis, and we'll image the full width of the subscapularis in long axis as we're going from superiorly to inferiorly and then back superiorly again. And again, this is the subscapularis coming across the humeral head, inserting at the lesser tuberosity, and we are able to image some of the myotendinous junction because of our patient positioning. Here, the subscapularis does appear normal without any thickening, without any discontinuity, and without any cortical irregularity at its insertion. And again, it's important to pay attention to the upper 50% of the width of this tendon to fully evaluate the tendon and make sure that there's no pathology throughout the entire width. We'll then move into dynamic scanning of the subscapularis. This is helpful for this patient, especially because she was complaining of clicking. So what we're going to have the patient do is actively, internally, and externally rotate the shoulder in the neutral position. And we're looking for a few different things here. As the tendon passes underneath the coracoid, we're looking for any type of subcoracoid impingement. We could look for subcoracoid bursopathy here. And then as they externally rotate, we want to look for any motion of the biceps tendon if it's subluxing out of the groove, as this is common with pathology to the subscapularis or the transverse humeral ligament. Here, things do appear normal. There's no bursal effusion here. There's no subcoracoid impingement that's imaged, and the biceps tendon is staying within the groove. Our next structure that we're going to take a look at as we're in this region is we're going to pop up to the AC joint. So from the subscapularis, we're going to scan up superiorly and identify the AC joint. For beginners, sometimes it's a bit easier to place the probe in parallel over the clavicle and slide the probe laterally until we identify the classic bony structures of the AC joint with the acromion laterally, the clavicle medially, and the acromioclavicular ligament coming over the top. Most newer machines are going to be able to pick up a little bit of the supraspinatus running deep to the AC joint as well. And you want to make sure you're scanning the entire width of the AC joint. We're looking for any type of cortical irregularity, effusion, synovitis, or advanced degenerative changes here. And again, this patient's AC joint does appear normal. So I broke down the report kind of regionally just to keep it fresh as we're going through this. So our biceps tendon, there was no abnormality in the biceps tendon, which was intact within the biceps groove without evidence of tendinosis or tenosynovitis. The subscapularis was intact without evidence of tendinosis or tear. There was no subcoracoid bursal effusion or long head of the biceps tendon subluxation with dynamic internal rotation, and the AC joint appeared normal without effusion, synovitis, or advanced degenerative changes. Next, we'll move on more to the superior shoulder with the supraspinatus. There's a lot of sonographers that save this to last because this is where most of the pathology in the shoulder scan is going to take place, and they don't like to become clouded by this pathology that they find there early on in their scan. However, I did scan the supraspinatus at this portion of the scan for this patient. So it's important to place the patient in the modified CRAS position to expose the tendon from underneath the acromion and also put that tendon under tension. When you have the patient go into this modified CRAS position, it's also important to instruct them to point their elbow towards the wall behind them and not let their elbow splay out. If they go into too much internal rotation, the most anterior fibers of the supraspinatus will become clouded and they won't be able to be imaged as they'll be too far in internal rotation. So just have them get into that correct positioning. As you're beginning to learn the scan, or I even still do this, is when I'm imaging the most anterior fibers of the supraspinatus, I align myself with the biceps tendon in the long axis first as it reaches its interarticular portion, and then slide laterally until I get this appearance of the supraspinatus inserting on the greater tuberosity, the superior facet of the greater tuberosity. Just helps identify the supraspinatus in the appropriate plane, but also get those most anterior fibers. So here we're looking at the supraspinatus coming over the top of the greater tuberosity and inserting on that superior facet. As it gets to its insertion at the superior facet, there are some splay of these tendon fibers, and this does impact the echogenicity of these fibers due to anisotropy as they reach their insertion. So you may need to heel toe during the scan in order to get appropriate imaging of those fibers. We also have the subacromial subdeltoid bursa coming over the top, underlying the deltoid. So here we're looking for our classic findings of tendon pathology, especially cortical irregularity, any change in caliber to the tendon, or overlying bursal pathology. Here, the patient's tendon does appear normal in the long axis. We also want to scan the full anterior posterior width of that tendon. So as we start anteriorly, we do want to scan posteriorly until we see that infraspinatus start to come into the picture. Make sure we're getting an idea of the full thickness health of the tendon. Flipping the probe 90 degrees, some people say we're going to point the probe towards the belly button now. More of that, the medial end of the probe is going to be pointed inferiorly to get that probe in the appropriate short axis. Here you want to make sure that you have the long head of the biceps tendon in the image, again, to get more of those anterior fibers of the supraspinatus where most of the pathology is going to take place. And then we want to scan from the distal insertion on the greater tuberosity more proximally as it reaches towards its myotendinous junction to evaluate the health of the supraspinatus. Here, we're looking for those same signs: cortical irregularity, changes in caliber to the tendon, overlying bursal pathology, and for this patient, things to continue to appear normal here. So for our report, supraspinatus was intact without evidence of tendinosis or tear. There's normal appearance of the muscle belly without evidence of fatty infiltration or atrophy. And the subacromial bursa, there was normal amount of fluid within the subacromial subdeltoid bursa without significant thickening of the bursal walls. Now we're going to move to the posterior shoulder. And in the beginning, finding the infraspinatus is a little bit easier if you align the probe in parallel with the spine of the scapula and then slide just inferior to that spine of the scapula until you find the characteristic intramuscular tendon of the infraspinatus. It's this long wispy tendon that reaches back into the infraspinatus muscle belly, and then slide laterally towards its insertion at the middle facet of the greater tuberosity. I like imaging this tendon with the arm in the adducted and internal rotated position to put some tension on that tendon and pull it further laterally towards its insertion. You do want to scan the full anterior, superior to inferior width of this tendon and long axis. And we're looking for our signs of tendon pathology, any cortical irregularity, which we do see here as we scan through the tendon, any thickness of the tendon, which we do see some thickness, which is more notable in the short axis scan, or any type of focal deficit within that tendon as well. So we do see that thickness of the tendon. We do see some cortical irregularity here in the infraspinatus. Then we'll flip the probe into the short axis, and we'll maintain the same patient positioning, but we'll have the probe oriented in the sagittal plane. And we are going to scan from lateral to medial on that tendon, again, to evaluate that tendon as it goes towards its myotendinous junction. We see some thickening of the infraspinatus tendon here, both in the still shot image as well as in the video. And as we scan medially, we do see evidence of this cortical irregularity deep to the infraspinatus tendon as well. Next up is the teres minor. It is a little bit difficult to find the teres minor at first when you're first learning the scan. There is a characteristic way to find the teres minor by scanning in the sagittal plane, having both tendons in short axis. Scan towards the posterior rim of the scapula, and as you transition from the infraspinatus fossa to the teres minor, where it comes off the scapula, there's this characteristic ridge in the scapula, and this will help you differentiate the two muscle bellies and intramuscular tendons, and then you could scan that back out laterally, following that teres minor tendon as it inserts on the inferior facet of the greater tuberosity. So here we have the teres minor both identified in short axis here, and then in the long axis position inserting on the humeral head. This is the least likely the rotator cuff tendon to have isolated pathology, but it is the most common muscle to have asymptomatic fatty infiltrate of this muscle. So just important to take things into context when you are imaging the teres minor. So for our report, the infraspinatus is intact. There was thickening and increased hypoechogenicity of the insertional fibers. There was normal appearance of the muscle belly without fatty infiltration or atrophy. There was cortical irregularity with apparent depression of the cortex deep to the insertional footprint of the tendon on the greater tuberosity. And for the teres minor, it was intact without evidence of tendinosis or tear. There was normal appearance of the muscle belly without evidence of fatty infiltration or atrophy. Rounding out the scan here, moving towards that posterior glenohumeral joint. So to identify this, as I showed before with that axial MRI image, you do just want to get aligned over the infraspinatus and scan medially, and then you'll see that characteristic appearance of the posterior glenohumeral joint with the posterior humeral head, the overlying articular cartilage, the labrum sitting on top of the glenoid, with the deltoid and the infraspinatus lying superiorly to that. The patient can maintain that either hand across the chest position or the neutral arm supinated position to get this image. And here we do see a little bit of that cortical defect sitting at the lateral edge of the screen. We see the glenoid, we see some of the labrum, which some of the labral pathology here will come more into picture when we get into some of these dynamic images with the overlying musculature. Now, there's no effusion present here, so you want to make sure to identify any joint effusion. You could look for any cortical changes or any loss of cartilage here, or you could look for any posterior labral pathology in this image. Because of this patient's complaints, I did decide to do some dynamic testing at this point as she was having pain as she went to external rotation, both with throwing and with lifting. This first image is just dynamic external rotation at that neutral position. As we bring her into external rotation, we can see the infraspinatus and that cortical defect come into contact with the labrum. She did have increased pain as she got into this position here. Then, due to her increase in pain and clicking when she got into the late cocking position, I did decide to image her in that position as well. So I had her go into dynamic abduction and external rotation as if she was reaching back to throw a ball, or as if she was getting into position to do a military press. And here we could see increased contact of that infraspinatus, that cortical defect with the labrum, and displacing that labrum even further as she gets into that position. When she got into the terminal aspect of this position, as we saw that labrum go into motion, she did also have a palpable and audible click that was painful to her as she got into that position. Due to those dynamic findings, I did decide to look at that defect location a bit closer to further identify what we were seeing with this cortical irregularity. And as I scanned initially, found the footprint of the supraspinatus and scanned posteriorly, it became apparent that the finding of that cortical defect was right at the region as the infraspinatus started to come into the picture, scanning posteriorly from that supraspinatus. Our last dynamic maneuver here, we just decided to look at dynamic abduction as well due to this patient's complaints. So we had the medial end of the probe situated over the acromion with the lateral end of the probe imaging the supraspinatus tendon and the bursa, and we had the patient go into dynamic abduction. Here we could see no collection within the bursa as she gets to that abduction position, and no significant compression on that supraspinatus tendon here. So for our report for the glenohumeral joint and labrum, there was degenerative fraying of the visible portion of the posterior glenoid labrum. This did come more apparent on the dynamic testing images. There was no glenohumeral joint fusion or arthropathy. And then for our dynamic testing, there was visible contact of the infraspinatus tendon with the glenoid labrum, as well as with the underlying cortical cystic change. The contact caused displacement of the labrum with compression between the glenoid and the humeral head cortical cystic change. There was a palpable and painful click that correlated with this contact. There was no evidence of subacromial rotator cuff impingement on dynamic shoulder abduction. There was no evidence of subcoracoid impingement, subcoracoid bursal effusion, or long height of the biceps subluxation with dynamic internal rotation. And last but not least, just finishing up the scan here, the complete ultrasound protocol scan. We did take a look at the spinal glenoid notch. So in order to image this, we slide medially from the posterior glenohumeral joint. We may need to add some heel toe pressure and some inferior wag in order to align the probe beam correctly with this spinal glenoid notch and in order to appropriately brighten up the cortex here. Here we're looking for any space-occupying lesions, such as a paralabral cyst that may be compressing on the suprascapular nerve and causing a suprascapular neuropathy. I also like to do a dynamic maneuver here to look for engorgement of that vessel and in order to elucidate if there is a mass there, if it does change with arm positioning to further rule out pathology. From the spinal glenoid notch, we will scan superiorly to the suprascapular notch. Here, we're going to scan towards the head. We're going to have the probe beamed more directly pointing in the coronal plane directly down towards the superior portion of the scapula here. We're going to find this characteristic appearance of the superior portion of the scapula where the suprascapular notch lies. We'll have the transverse scapular ligament coming over the top with the suprascapular nerve and vessel sitting deep to the supraspinatus. Here again, we're looking for any space-occupying lesions, and this is also a helpful image for procedurally to do a suprascapular nerve block. Here, things do appear normal. And last but not least, the coracoacromial ligament, again, rounding out our scan. If you align the medial end of the probe with the coracoid and pivot the lateral end of the probe superiorly until you reach the acromion, you'll find this characteristic fibrillar appearance representing the coracoacromial ligament. Here we could look for any disruption in that ligament, and we can do some dynamic testing to look for impingement under the coracoacromial ligament as well. So for our patient, what we did discover was evidence of internal or posterior superior impingement. Sometimes those terms will be used interchangeably. This does commonly impact throwers, swimmers, volleyball players, tennis athletes, any athlete that's going into that increased capacity of external rotation and abduction away from the body. The maximal range of motion into abduction, external rotation during overhead throwing can lead to increased contact between the greater tuberosity and the glenoid. And this is also exacerbated by the development of GERD and the development of anterior joint laxity in these athletes. Although this is adaptive for their sport, it does shift the contact point of the articulation between the humeral head and the glenoid and can leave them susceptible to internal impingement. Repetitive contact between the greater tuberosity and the glenoid can cause injury to the rotator cuff, the labrum, and the greater tuberosity. And common findings that we will see with this are articular-sided rotator cuff tears, posterior superior labral tears or calcifications, as well as greater tuberosity cystic changes, as you can see here on this MRI of a patient with internal impingement. And again, this is not our patient. This is an image from the literature. So there are different types of humeral tuberosity cystic changes. You can see this bare area cyst, which is just an asymptomatic cyst associated with aging. You can see lesser tuberosity cysts associated with subscapularis pathology, anterior greater tuberosity cyst associated with the anterior rotator cuff tears, such as the supraspinatus, and then posterior greater tuberosity cysts, which are associated with infraspinatus pathology or internal impingement. There's also subchondral cysts that are related to our classic degenerative changes with osteoarthritis, as well as rheumatoid arthritis and trauma. And this is a good breakdown of those different humeral tuberosity cystic changes from the MSK MRI Instagram page, which a physician that puts out great information regarding MSK radiology. So for a report pointing out the pathologic findings on a report here, so for the infraspinatus, it was intact with thickening and increased hypoechogenicity of the insertional fibers. There was normal appearance in the muscle belly without evidence of fatty infiltration or atrophy. There was a subcortical cystic change with apparent depression of the cortex deep to the insertional footprint of the tendon on the greater tuberosity. And then for our dynamic testing, there was visible contact of the infraspinatus tendon with the glenoid labrum, as well as underlying cortical cystic change. This contact did cause displacement of the labrum with compression between the glenoid and the humeral head's cortical cystic change. There was a palpable and painful click that correlated with this contact. So for our impression here, there was evidence of internal impingement with coinciding infraspinatus tendinopathy, greater tuberosity subcortical cystic change, and degenerative labral tear with evidence of contact between the structures on dynamic examination. So for this patient, we did offer her a corticosteroid injection into the joint at this time due to the discomfort that she was having, as well as physical therapy. She did defer the injection, but opted from time off from overhead activities such as throwing and weightlifting, and she worked with a PT specialized in working with overhead throwing athletes. She progressed quickly to a home exercise program focused on scapular retraining. At 6 months post visit, she's doing well and plans to play softball this summer. My references are listed here, and I'm excited to open it up to questions and discussion.
Hey George, that was great. This is Doug Hoffman. One quick question. What did you think the clicking was due to?
I think that sure, there may have been some anterior laxity that she was experiencing, as I discussed with some of those changes that could be associated with GERD and repetitive overhead throwing. Uh, I think I tried to get some imaging, as Dr. Mountainer recommended, anteriorly in the joint and putting her back into that externally rotated and abducted position and getting a good image to see if I could see that humeral head sliding forward relative to the glenoid. I was unable to capture that image, unfortunately, but that's somewhat what I'm thinking of is she had some anterior joint laxity there.
So it wasn't just like localized clicking to the posterior glenohumeral joint.
No, it felt like it was deeper than that, but I do think some of the pain that she was experiencing was associated with as that humeral head was sliding forward, that contact between the glenoid and the labrum. Sorry, the humeral head and the labrum.
Got it. Thanks.
Well, George, thanks for that excellent and thorough presentation. Honestly, don't really have too much to add as far as the protocol. I think you hit home all the dynamic testing that you want to do for the shoulder, especially kind of the more atypical ones, like you had mentioned in this case with the posterior shoulder. And then the other one that I think people don't think of as frequently, you had mentioned right at the end, is that coracoacromial impingement as well too, which I think we're finding out is more frequent than the supraspinatus and subacromial bursa. So just getting used to scanning that as well too. And then the other thing I just wanted to kind of, I guess, bring up for discussion or talk about as well too is that last slide that you had mentioned with the subchondral cysts along the different areas for the humerus. Yeah, I think this is something that's challenging as we're going through these scans. As I always say, use these cortical irregularities along the humerus as almost a lighthouse. Sometimes that, hey, if you're seeing that, there's probably likely some pathology there. But obviously, I think with the literature within the shoulder, that's not always the case, that some of these can be asymptomatic findings. I think we see that most frequently within the lesser tuberosity and then as well too along that posterior humeral head with the infraspinatus. I think in your case, honestly, that irregularity was so large that I would have to think it would be pathologic versus then some of the more subtle irregularities. But the one time that usually it always does correlate to pathology I see is within that greater tuberosity with the supraspinatus. So something to just know, and I don't know if that's been the experience of others, scanning in this areas as well too. But I think your case definitely highlights like I think depending on the size of the regularity as well too, definitely need to hone in more, on pathology to that area because it definitely can be indicative that there's, something else going on. So
Yes, Stephen, my experience has been in correlating these small subchondral cystic structures is they're frequently more asymptomatic with the infraspinatus, and typically they're associated with some beginning or overt articular side tearing of the supraspinatus when correlated, with the set. So, yeah, it doesn't mean it's symptomatic, but usually when I see those erosions under the supraspinatus, I'm seeing some undersurface articular side tearing.
all right, well, let me see if we have any other questions. Just opening up for discussion. I don't see anything in the chat right now. Don't
I
know
had
if,
a few comments.
yeah, yeah.
First of all, that was top notch, George. That was
Thank
a
you.
great presentation of the shoulder, great images. I don't think we fully appreciate the spectrum of pathology of the infraspinatus. I mean, we all have seen tears. One thing I might encourage you to try is I've sort of morphed into when I image the infraspinatus, I actually externally rotate forward flex, and AD, duct to shoulder. And it opens up the long axiom, the short axis of the tendon.
Mm.
And I learned that from a mentor of mine in Paris. And he when you do that, you actually see things you don't see in the more traditional position with the arm AD duct. And you often see some intersubstance tearing. And we're not
Mm.
quite really sure what that means. It's not present on MRI, or you can't see it on MRI. And so again, I mean, we talk about these cortical irregularities of the infraspinatus. I just don't feel like we fully have understood that muscle in terms of pain and degenerative changes. The second comment I would make is if you're scanning a lot of shoulders, what I've learned over time is we talk about reach structures in AMSSM. I would call these reach areas because the more shoulders you scan, the more you sort of venture into these areas and related pathology, and learning the structures in those reach areas can be incredibly helpful. So, like anteriorly, that reach area would be scanning down the anterior humerus and the coracobrachialis, the pec major, pec minor, cords of the brachial plexus. Going cephalad, brachial plexus. And you don't need to be expert in the brachial plexus, but to be able to scan proximally and link some of these nerves together and structures together. Just last week, I had someone referred to me with Parsonage-Turner syndrome. They wanted me to look in the suprascapular notch. Look normal. It's hard to see details of the nerve, but I scanned more proximally to the suprascapular nerve, and it was a huge, large nerve
Huh.
coming off C5-6. So this the ability to do that, going laterally and posterior laterally, the teres major lat dorsi area, the anterior inlet of the quadrilateral space, the scapulothoracic area, the posterior quadrilateral space. Those are all reach areas that if you're doing shoulders on a regular basis, you're going to find yourself venturing into those, and knowing those structures or learning those structures can really expand your ability to diagnose shoulder problems. So that's just a comment that I found over the years that I've sort of morphed into is learning these reach areas, not just one structure, but the whole area themselves. So anyway, great presentation.
All right. And then, George, I think we got one question that came up. Um, what said, what clinical test was positive for this patient? Um, we talk much more about the supraspinatus. Um, obviously more than the infraspinatus, especially for the overhead throwers. So yeah, I know maybe you went something through the clinical presentation, but was there anything that honed you on specifically for this athlete
Yeah,
that
some
would
some of her
indicate
labral
this?
some of her labral testing was positive. I did like classic O'Brien's test, but then just like doing some axial compression like crank test through that joint was also positive as well. And then she did have pain with resisted external rotation, both at the 90-90 position and at just at her side and neutral. So I did suspect that there was some rotator cuff pathology of some sort going through there with that pain with the external rotation.
Yeah, I will say for yeah, to kind of reiterate that, George, yeah, for these athletes, especially overhead, if you're finding, more posterior labral pathology, I mean, I would most of the time for these, you had mentioned the O'Brien's, obviously that can pick up a lot of other pathology outside the labrum. But honestly, majority of the time, what I'll do is, and then just like you had done for the ultrasound scan, is get them into their throwing motion, whatever their overhead motion is, whether it's a volleyball player or a baseball player, and get them into that throwing motion and then apply, stress in that area while also trying to stabilize, somewhat the arm and the shoulder. And a lot of the time then they can isolate and recreate, that pain, especially towards the posterior shoulder, and then potentially that labrum and the rotator cuff. And that's where I'd say that there's not like, I think, specific exam maneuvers, always, for these, but obviously just recreating, the motion, that they're noticing those symptoms in is what I've typically done for these overhead athletes. All right. Otherwise than that, I think that will conclude today's ultrasound case series presentation. So once again, thank you so much, George.
Thank you for having me.